Our topic this month is the Cardiac Arrest Registry to Enhance Survival, otherwise known as CARES. What is CARES? Well, CARES is a collaborative that started between the CDC and Emory University. It was originally set up by a physician who practices at Emory University in the emergency department by the name of Brian McNally. And this database was set up to gather and report data for out-of-hospital cardiac arrests, which we also call OHCAs. In Ohio, Cincinnati, and the Columbus fire departments have been participants since almost the beginning. The program has evolved and is now a freestanding entity with support from Medtronic and Physio-Control, and is available to participating entities by membership. MEC joined the CARES database effective January 1st, 2016, and all of the MEC members have data entered into this database. This is a map that outlines those locations that utilize CARES. Those states that are highlighted in yellow are considered or called CARES states. Those are states where their government has decided all EMS providers will enter data into the CARES database. In Ohio, this map lists Columbus and Cincinnati, but there are a couple of departments up in the Toledo area, as well as our MEC members that participate in the database as well. Why do we participate in CARES? Well, you can't improve what you don't measure. For those of you who have been through the Resuscitation Academy, one of the mantras is measure and improve, measure and improve. So you don't know what you can improve if you don't measure. Through measurement, we do make informed decisions, and we can identify and replicate best practices from across the country. Our performance in resuscitating victims of out-of-hospital cardiac arrest is a good and direct measure of our performance as a system of care. And CARES helps us identify areas of improvement, including opportunities that we do not directly control, such as dispatch center performance, rate of bystander CPR performance, AED placement, and so on. And finally, we participate in CARES because the public and the communities we serve expect us to do well, and CARES allows us to improve what we do and also to give our performance, or show our performance to those communities we serve. One of the key metrics in the CARES database is the Utstein arrest. What's a Utstein arrest? Years ago, experts in resuscitation met in Utstein, Norway, to identify metrics which could be used to measure pre-hospital performance in managing out-of-hospital cardiac arrests. I think we all recognize that witnessed shockable rhythms have the best outcomes. So by definition, a Utstein arrest is a witnessed arrest that has a shockable rhythm. And a Utstein bystander's arrest is a witnessed arrest with a shockable rhythm, and a patient received either bystander CPR or activation of AED or both. It's the Utstein bystander arrest that we expect to have the best potential outcome for recovery after surviving, or actually after suffering an arrest. One of the things we look at as part of the Utstein arrest is the patient's cerebral performance category, or CPC score. This is done at the time of patient discharge if they survived to hospital discharge, and it's a measure of what's their neurological status at that time. Our interest is to have the highest possible number of survivors have a CPC 1 or 2, with CPC 1s having a good cerebral performance, which by definition are conscious, alert, able to work, or they might have mild neurologic or psychologic deficit, but which can be easily accommodated. CPC 2 is a moderate cerebral disability. These patients are conscious, they have cerebral function for independent activities of daily life, but they require some sheltering and assistance. CPC 3s are conscious, but they are totally dependent on others, and they may be ambulatory, or they may be demented, or be suffering from paralysis. And then CPC 4 patients are those who are comatose or in a permanently vegetative state, and this is the worst possible outcome in which the patient might survive. There are some, or there has been some data published through this CARES. I've got a couple slides from the CDC, and this is an example of why we participate in CARES. So this is a list of 46 different departments that participate in CARES, and this is their Utstein survival rates, October 2005 through December 2010. And you can see that the average survival rate is 30%, but you have some players who are way below that and others that are substantially above that. We're in the process of just learning now where we fall on this map. CARES also can identify the types of arrhythmias that patients suffer, and this is a graph of the presenting rhythms, and it's also broken down by age group. And I think we can see that asystole seems to be the most common presenting arrest rhythm for our patients, but it does vary somewhat based upon age. And then the last slide from the CDC is just an outlook at the CPC score for patients based upon their presenting rhythm, with patients who have the highest CPC1 rate being those who have a VFib or VTAC arrest, and those with the poorest are those who are in asystolic arrest. So these are examples of what we can gather and garner through the CARES database. When we talk about the CARES database and the report format that we receive several different types of reports, and what I like to do now is review the two reports that I think are the most common, and these reports are for our performance in 2016 for MEC EMS as a whole. I'm presenting the aggregate report for two reasons. One is each individual department's report is available, but is really the property of each department, so it's not for me to release their individual reports. And the other reason that we look at the aggregate is most of us, or most of our departments, do not have enough cardiac arrest by ourselves or by each individual department for the data to be statistically significant. So for MEC EMS, we are looking at the aggregate report. One of the two formats that we receive is the Utstein survival report. This is actually a 3-page report. What I'm giving you is resuscitations for patients who undergo non-traumatic cardiac arrests, in which case the arrest is witnessed. So this then falls into the Utstein criteria as a witnessed arrest. You look at the green arrow, the top right box, it indicates our Utstein survival rate and our bystander rate. So the survival rate of 25% means that for witnessed shockable rhythms, we are able to salvage 25% of those patients, or in other words, 25% of those patients survive to hospital discharge. And the Utstein bystander rate, where the patient actually had a shockable rhythm and they received bystander CPR or AED use, their survival rate was about 23%. So if you look at this algorithm, let's go straight down the middle. The second green arrow talks about the witnessed arrest. Again, that's one of the criteria for a Utstein arrest. And their initial rhythm, the third arrow down, shows the initial rhythm of VFib or VTAC, and we had 20 of those patients out of 155 resuscitations attempted. Going all the way down to the bottom, we then look at patients who survived to hospital discharge and their CPC scores. So we had 5 of 20 patients survive for discharge from the hospital, and 5 of those 5 had a good or acceptable CPC score of 1 or 2. So kind of reiterating what's on this graph, we had 155 cardiac arrests among our member agencies in 2016. These are arrests that were where resuscitation was attempted. Of those 155 arrests, 52 were witnessed. Of those 52, 20 were a VFib or VTAC arrest. We worked those patients, and 5 of the 20 survived to discharge, which is 20%, and all of those patients had a suitable CPC score. We also had some patients who had asystole or other rhythms, and we had a total of 5 patients with other rhythms that survived discharge and 2 that were asystolic. So of our 155 arrests, we had a total of 12 patients survive to discharge. The other report I'd like to briefly discuss is the CARE Summary Report. This is basically a long list of different parameters that we measure through CARES. On the left-hand column and the right-hand column have to do with national statistics, with our MEC numbers in the middle column. For the next couple of slides, I've extracted the all agencies and the MEC agencies, and I wanted to compare some of that data. So if we look at some of this data, approximately 33% of our patients were witnessed versus 37%, so actually about 64% of our patient or cardiac arrests are unwitnessed versus the national average of 50%. So we have a considerably higher rate of unwitnessed arrests. We differ from the national average by about 14 percentage points. Who initiated CPR? We actually did better than the national average in terms of bystanders starting CPR, 45% versus 40%. And was an AED applied prior to EMS arrival? And our utilization rate was lower. Why was this lower AED utilization rate lower? Possibly because of lack of access. Patients may arrest in a public location, does not have an AED available. Another possibility is, it's not, I didn't copy it and paste it here, but we actually have a greater frequency of cardiac arrests at a patient's home or at an ECF, and research has shown that patients who have a cardiac arrest at home or an ECF tend to be sicker, therefore they're more likely to die after suffering a cardiac arrest. Some additional data, the initial rhythm for us, even though we have a higher rate of unwitnessed arrest, we also have a higher rate of shockable rhythms at 27 or 28% versus 20%. But we unfortunately have a much less than average or less than national likelihood of obtaining ROSC on a patient, ROSC being return of spontaneous circulation. And by definition, you have to have return of circulation for 20 minutes or more before it's considered ROSC by CARES. If you look at outcome, we pronounced about 8% of the patients in the field versus a national average of about 32 to 33%. We had an overall survival to discharge, not a whole lot different from the national average, 10.3% versus 10.8. Our cerebral performance score was also about the same. But if you look specifically at Utstein survival and Utstein bystander survival, we are a little less, or we are less than the national average. We are at 25% versus a national average of 34%. And for the Utstein bystanders, we're at 23% versus 38%. So if you look at across the country, places like Seattle and Rochester, Minnesota have a Utstein bystander survival rate that's over 60%. This slide also suggests that perhaps we could terminate more resuscitations in the field if we're terminating about 8% of our resuscitation in the field versus a national average of about 32-33%. This is something we're going to look at as we revise our protocol for 2018. I may tweak the termination resuscitation protocol or clinical standard so that we're a little more comfortable and aggressive in terminating in the field, particularly for those patients who have no likelihood of survival. So looking at this, why does MEC EMS have a low success rate in terms of our Utstein survival rates? Well, we have more arrests at home or in an ECF, and again, resuscitation research has shown that these patients are sicker and more likely to die. We have a greater number of unwitnessed arrests, so if somebody goes down and the arrest is unwitnessed, we have no idea how long they've been out, and studies show that for every minute delay in initiating CPR, your likelihood of survival drops by 10%. So if somebody has no bystander CPR for 5 minutes, their likelihood of survival is 50% lower than somebody who has CPR started immediately. Another item to think about, and I don't have an answer for this, I've asked CARES if they give us an update, is could there possibly be some relationship to our EMS travel time? We are a system, we are in part urban, we are part rural. If it takes more time for first responders or the medics to arrive on scene, we would then expect that initiation of BLS and ALS will take longer, and this may also result in poorer outcomes. Again, this is just a thought. I don't have any data to suggest that EMS travel time truly has made a difference in our success rates, but it's something we should look at. What can you do? Well, I think the first thing is continue to provide the best possible care for our patients. Continue to practice and perform high-performance CPR. Review your agency's CARES report. It's available through your chief or your EMS coordinator. Look at the data, see where you do well, see where you did not so well, and think about how you can improve and pass those ideas on. We're always interested in hearing how we can do things better. And then document well. It's possible that some of our CARES data may be skewed a little bit because some items may not be appropriately documented. And if you look at documentation, it really is, at least from the data perspective, garbage in, garbage out. So if we don't put good data into CARES, our performance is not going to look as good as if we put the correct data in. So some things for you to consider or to make sure you document is, was the arrest witnessed or unwitnessed? A witnessed arrest by definition is the patient is either seen or heard to go down. So if mom's in the kitchen and dad sees her fall to the floor, or if dad is in the other room and hears her fall to the floor, that's considered a witnessed arrest. If dad's outside in the garden, walks inside, finds mom down on the floor, that's an unwitnessed arrest because we don't know when she went down. Document what circumstances led to the arrest. Was this a traumatic or non-traumatic arrest? So by definition, a CARES patient is a non-traumatic cardiac arrest that receives either defibrillation by a bystander or who has any resuscitative efforts provided by EMS. So if you arrive on scene and provide CPR or any interventions or defibrillation, that's a CARES case. If the patient has CPR started by a family member, but the patient does not receive electric shock prior to your arrival, you arrive on scene and you elect not to resuscitate the patient, then that is not a CARES patient because bystander only CPR with no intervention by EMS does not qualify as a CARES case. However, if the patient's in the middle of Home Depot, suffers a cardiac arrest, and somebody uses an AED at Home Depot before you arrive, that is considered a CARES case. Document whether or not the dispatcher recognized the patient was an arrest and recommended compression-only CPR. Document whatever care was provided by bystanders, whether CPR use or AED use. What was that initial rhythm on arrival? Was this a VFib? Was it VTAC? Was it asystole or PEA? And then whether or not there was ROSC. And again, ROSC is defined as spontaneous circulation for 20 minutes or more. So that concludes the presentation. I thought it was important that you be aware of the CARES information in the CARES database and that you have access to the information so you can review the performance of your agency as well as MEC as a whole. If you have any questions about this presentation, please post them on Workplace and I will get back to you. Thank you.